So this is landmark publications in colorectal cancer. We will move to through colon and rectum separately, and I have tried to include the chemoimmunotherapy separately, surgery, radiation therapy, and then a word or two about screening in colorectal cancer. So we will go on to the presentation. So I would like to quote Isaac Newton here. If I have seen further than others, it is by standing upon the shoulders of giants. So I have tried to include the recent landmark publications in colorectal cancer, but let's not forget where we came from. And these were a few publications that came on earlier, which paved way for the current standard of care in colorectal cancer. The first one is by Harrington Janeway, who pioneered the radiation therapy in rectal cancer, not just rectal cancer, but in cancers of tongue, tonsils, etc. The second one would be the landmark publication by Bill Heald, wherein he introduced the technique of total mesorectal excision, which reduced the recurrence rate in rectal cancer by a huge margin. And then the third one would be Angelita Hebagama, who introduced the wait and watch concept in colorectal cancer following neoadjuvant for organ preservation. So many more papers, the Swedish trial, the German trial, all of which led to the standard of care, which is right now for colorectal cancer. So I'm sure all of you are aware of how the clinical trials work. They are done in 4 phases. Phase 1 is for focuses on the safety. The phase 2 focuses on the effectiveness and the side effects. Phase 3 compares new treatment to existing treatment, and phase 4 is the treatment which is approved and available, and it is the post-marketing where you observe the long-term effects. So we will be talking mainly about the phase 3 trials and a few phase 2 trials. Moving on to the first trial in colon, covering the chemo and immunotherapy. We will move on to the first trial. This is the NeoCol trial. NeoCol trial is a Scandinavian trial based in Denmark, Norway, and Sweden. It was published in the Journal of Clinical Oncology by Lars Jensen et al. In 2023 June. And it compared, basically, it looked at neoadjuvant chemo versus standard upfront surgery in locally advanced colon cancer, that is T4 or T3 with more than 5 mm of invasion depth, and nodes N0 to N2. They looked at 248 patients, which is again a multicentric trial. The neoadjuvant group received either 3 cycles of Capox or 4 cycles of Folfox before the surgery, and the standard group underwent upfront surgery with adjuvant chemotherapy based on the stage. The primary endpoint was 2-year disease-free survival, and the secondary outcomes they looked at was overall survival, post-op complications, and the number of chemocycles that was used. As you can see from the survival graph, the disease-free survival was comparable in both groups, but the number of cycles of chemo that was required in the neoadjuvant or the adjuvant setting was fewer in the neoadjuvant setting, median 3 versus 4 in the standard group. And the postoperative complications, surprisingly, was again higher in the standard group compared to neoadjuvant group. That is the ILS, the anastomotic leakage, and the hospital stay. And the adjuvant chemotherapy, the number of patients who required adjuvant chemotherapy was again lower in the neoadjuvant group. So this was the outcome of NeoCol trial. Again, next we have the Foxtrot trial. It is a UK-based trial. Again, was published in the Journal of Clinical Oncology in 2023 March by Dion Morton et al. And it looked at preoperative chemotherapy for operable colon cancer. Again, we are looking at neoadjuvant versus post-op chemo for locally advanced colon cancer, that is T3 to T4, node 0 to 2. Again, they had over 1,000 patients, and the neoadjuvant group received 6 cycles pre-op 5-FU based chemo and 18 weeks of post-operative chemo, whereas the control group received 24 weeks of adjuvant post-surgery. And a subgroup of patients with RAS wild-type tumors were further randomized to receive panitumumab or not to receive panitumumab. And the primary endpoint was the local control, that is the residual disease or recurrence within 2 years. And the secondary outcomes included surgical morbidity, stage, tumor regression, completeness of resection, and cause-specific mortality. So when you look at the 2-year recurrence rates, the recurrence rates were 22 versus 29 in the neoadjuvant group. So the neoadjuvant had a lower recurrence 2-year recurrence rate. And when you look at the secondary outcomes of feasibility and safety, 96% of the neoadjuvant chemo patients started the treatment, and 87% completed it. 4% required expedited surgery because of obstructive symptoms, and fewer serious post-op complications occurred in the neoadjuvant group. Again, there was significant tumor downstaging and histological tumor regression, which is again statistically significant. And the completeness of resection was also 94% in the neoadjuvant group versus 89% in the control group. In the subgroup analysis, the panitumumab did not enhance the benefit of neoadjuvant chemotherapy. So that was the outcome of Foxtrot trial. They concluded that when given preoperatively, it produces marked histopathological downstaging, fewer incomplete resections, and better 2-year disease control. And they also noted that the histological regression after neoadjuvant chemo is a strong predictor of lower post-operative recurrence risks. So it has a potential use for guide as post-op therapy. So the regression after neoadjuvant chemo is a stronger predictor of lower post-operative recurrence risk. Coming to the next trial, this is the optical trial, which is again published in the Journal of Clinical Oncology in September 2024. It is a trial based in China by Huabin Hu et al. And again looked at neoadjuvant chemo versus upfront surgery in locally advanced colon cancer. Over 700 patients, and the neoadjuvant group received 6 cycles of modified FOLFOX or 4 cycles of CAPOX preoperatively, followed by surgery and adjuvant chemotherapy. The upfront surgery group underwent immediate surgery followed by adjuvant chemo. The primary endpoint again was 3-year disease-free survival rate, and the secondary outcomes looked at the pathological complete response, tumor staging, lymph node mets, and overall survival. So when they looked at the disease-free survival, it was lower in the neoadjuvant group, but it was not statistically significant. But the overall survival was lower and was statistically significant. Like I said, the 3-year disease-free survival was 82% in the neoadjuvant group versus 77% in the upfront surgery group, but it was not statistically significant. The pathological complete response rates were 7% in the neoadjuvant group with significant downstaging, and the lymph node mets were also with significant reduction in the lymph node metastasis also in the neoadjuvant group. The R0 resection rates were comparable, 98% in both groups, and the overall survival tended to improve with neoadjuvant, and it was, but it was not the primary endpoint that was there in the trial. Again, the neoadjuvant was well tolerated with no increase in surgical complications. So they concluded that neoadjuvant with FOLFOX6 or CAPOX did not show significant disease-free survival benefit. However, it was a safe approach with significant pathological downstaging and appears to be viable. This is an immunotherapy trial. This is published in the NEJM. This is a trial from Netherlands. It is a phase 2 trial. It compared the utility, the safety of neoadjuvant immunotherapy, that is a combination of nivolumab and ipilimumab in preoperative locally advanced mismatch repair deficient colon cancer. So basically, you looked at MSI high patients And in these patients, neoadjuvant ipilimumab nivolumab combination was used, and they tried to look at the safety, which was defined as timely surgery, that is less than 2 weeks delay in the planned surgery owing to the treatment related adverse effects. And they also try to look at the 3-year disease-free survival. This is a phase 2 trial. The survival data is not available. But the interesting fact is that the pathological complete response rates with these patients were to the tune of 68% in the this is the pathological complete response rates. They were to the tune of 68% in the neoadjuvant group. And grade 3 or 4 immune related adverse effects occurred in 4% of the patients. So significant complete response rates with neoadjuvant combination of nivolumab and ipilimumab, and this is the niche trial. Coming to surgical trials in colon cancer. So this is an Italian trial, the COMIN trial, which was published in the Annals of Surgical Oncology in March 2024, and by Maurizio Di Gulli et al. Basically looked at the conventional surgery for right-sided colon cancer and compared it to the complete mesocolic excision proposed by the Hohenberger group. So the COMIN trial, again, like I said, it compared CME versus conventional surgery in right-sided colon cancer, and it was a multicentric trial based in Italy. The interventional group, the CME group, the surgery involved complete mesocolic excision with central vascular ligation, and the conventional surgery group included the standard right hemicolectomy. And the primary endpoint was the 3-year disease-free survival, and the secondary outcomes they looked at included the safety outcomes, including operative duration, perioperative complications, length of hospital stay, and the oncological outcomes like lymph node yield, 3-year, 5-year overall survival, and 5-year disease-free survival, and the surgical quality, that is based on something known as the Ben score, which is based again on specimen length, mesenteric area and integrity, length of ileocolic and middle colic vessels. Because only the interim analysis is available, the survival data is not available. So this paper actually only looked at the lymph node yield and the surgical quality. When they looked at the early postoperative outcomes, the number of patients who required more than 5 years postoperative 5 days of postoperative stay were lower, around 60% in the CME group versus 72% in the standard right hemicolectomy group. But the postoperative complications based on the Clavien-Dindo scoring system was comparable in the two groups. When they looked at the quality of resection, they looked at the quality of resection based on this Ben score, and they found that the quality of resection was the lower the score, the better the quality of resection, and the lower scores were much higher in the CME group versus the non-CME group, and the complete mesocolic excision significantly increased the quality of resection. So that was their conclusion. And again, when they looked at the lymph nodal data, the number of lymph nodes retrieved was significantly higher, 25 versus 20 in the CME group. So higher lymph node yield again in the naturally when you go with central vascular ligation and central lymphadenectomy. But the survival data is still not available. So the final results are yet to come. So that is the COMIN trial. This is again another surgical trial, RELAC trial. So RELAC trial is a trial based in China. Again, they looked at extent of lymphadenectomy for surgical management of right-sided colon cancer by Liu et al. The RELAC trial again looked at conventional surgery versus CME in right-sided colon cancer, and over 1,000 patients with T2 to T4A and node positive and negative patients with right-sided colon cancer. CME group underwent central vascular ligation with complete mesocolic excision, and the D2 dissection group, standard lymph node dissection was taken care. And the primary endpoint was 3-year disease-free survival, and the secondary outcomes included the 3-year overall survival. This is a diagram depicting the line of dissection in CME versus the standard D2 lymphadenectomy. So basic difference you can see. You go to the left of the mesenteric vessels in the CME group, and in the standard D2 dissection you go to the right. So that is the difference. And when they looked at the outcomes, disease-free survival was comparable in the two groups. The overall survival was also comparable in the two groups. When they looked at the operative morbidity, the post-operative complications were comparable, but the incidence of vascular injury naturally in the CME group was 3% versus 1% in the D2 lymphadenectomy group. So comparable disease-free survival and overall survival with slightly increased risk of vascular injury in the CME group. When they did a subgroup analysis, they checked at the nodal positivity and compared it to survival, and they realized the N2 group, especially the N2 group, the survival advantage was significant in the CME group, and so they concluded that the trial failed to find evidence of superior disease-free survival or for CME compared to standard D2 lymphadenectomy. But in a specific subgroup with central mesocolic node positive preoperatively, it provided a significant survival advantage. So that is what they concluded from this. Coming to the next trial, this is the HYPEC T4 trial. This is a Spanish trial which is published in the JAMA Surgery in 2023 April, and by Alvaro Sanchez et al. It compared the efficacy and safety of intraoperative HYPEC for locally advanced colon cancer. Basically, it is a prophylactic HYPEC trial in T4 colon cancers, and it was based on mitomycin C. Patients were randomly assigned to receive cytoreduction plus HYPEC with mitomycin C or cytoreduction alone, followed by adjuvant. And the primary outcome they looked at was the 3-year local regional control rate. That is the defined as the proportion of patients without peritoneal disease recurrence. And the secondary outcomes they looked at were disease-free survival, oral survival, morbidity, and rate of toxicity. So when they looked at the local regional control rate, the HYPEC group had more than 10% better local regional control rate compared to the surgery alone arm. And but when they looked at the disease-free survival and the overall survival data, it was not statistically significant. So even though they could achieve better 3-year local control rates with HYPEC prophylaxis, they could not translate that to the survival advantage. So they concluded that the definitive subgroup with a pathological T4 disease showed a pronounced benefit with a 3-year local control rate after the HYPEC treatment. Moving on to rectum, we'll first look at the chemo or the immunotherapy in rectum. This is published in the NEJM in 2023 June. It is a multicentric US-based trial. This is the prospect trial, and it looked at preoperative treatment of locally advanced rectal cancer. Basically, it is a non-inferiority trial which tried to compare neoadjuvant chemo with FOLFOX with standard neoadjuvant chemo-RT. Over 1,000 patients, and T2 node positive, T3 node negative, T3 node positive are all and were candidates for sphincter sparing surgery. And the interventions included FOLFOX group received FOLFOX chemo, and chemoradiotherapy was given only if the tumor shrank by less than 20%, or if FOLFOX was discontinued because of side effects. So if they in the interventional group they gave FOLFOX, if the tumor has not shrunk by more than 20%, then they gave standard chemo RT, or if it was discontinued because of any adverse effects, then again they gave chemo RT. But otherwise they gave FOLFOX, and in the standard chemo RT they continued with chemo RT followed by surgery. And the primary endpoint they looked at was disease-free survival, and the secondary outcomes they looked at was overall survival, local recurrence, complete response, and toxicities. So they had a very tight eligibility criteria, and they ruled out any patient with T4 tumors, patients with 4 or more pelvic lymph nodes with short axis larger than 10 mm, or tumor visible within 3 mm of the radial margin seen on basic pelvic imaging. Within these tight criteria, when they looked at the patients, they found that the disease-free survival was comparable between the two groups, whether it was for neoadjuvant chemo or chemo RT. The 5-year disease-free survival was also comparable between the two groups, and the 5-year local recurrence rates as well as the 5-year overall survival was also comparable between the two groups. So they concluded that neoadjuvant chemo is in patients with locally advanced rectal cancer amenable to sphincter-sparing surgery. Neoadjuvant FOLFOX chemo with selective use of chemo RT was non-inferior to the neoadjuvant chemo radiation, and nearly 90% of the patients were able to avoid chemo RT. But you cannot generalize this because the limitation of the tight eligibility criteria that is used, and they have eliminated the high-risk groups. So within this group, you could try this neoadjuvant FOLFOX with selective use of chemo RT, only if the tumor response was less than 20%. So within this group, they showed that this was non-inferior to the standard neoadjuvant chemo RT. Moving on to this trial, this is a Stella trial, which is again based in China. They again looked at total neoadjuvant therapy versus long-term chemo RT in middle and lower rectal cancers. It was again a multicentric phase 3 trial, which is a non-inferiority trial. They tried to look at total neoadjuvant therapy, that is short course RT followed by chemo versus long-term chemo RT. And they looked at 599 patients in the distal or middle third rectal cancer, T3 or 4 and node positive. In the total neoadjuvant group, they gave short course RT 25 grays in 5 fractions over 1 week, followed by 4 cycles of chemo Capox. And in the chemo RT group, they gave long-term chemo RT along with sensitizing dose of capecitabine. And all of them underwent total mesorectal excision 6 to 8 weeks after the pre-op treatment. And the TNT groups received 2 additional Capox adjuvants post-surgery, and the chemo RT received 6 cycles of Capox post-surgery. And they looked at 3-year disease-free survival, and the secondary outcomes they looked at was metastasis-free survival, local regional recurrence, overall survival, and toxicity. So total neoadjuvant versus standard neoadjuvant chemo RT followed by adjuvant. So when they looked at the disease-free survival data, the disease-free survival at a median follow-up of 35 months, the disease-free survival was 64% in the total neoadjuvant group versus 62.3 in the chemo RT group. But there was no significant difference in metastasis-free survival or local regional recurrence. But again, the TNT group had a 3-year better overall survival than the chemo RT group. But if you look at the prevalence of acute grade 3 to 5 toxicities during the preoperative treatment, it was higher, 26.5% in the total neoadjuvant group versus 12.6% in the chemo RT group. So they concluded that short-term RT with pre-op chemo followed by surgery was efficacious with acceptable toxicity and could be used as an alternative to standard neoadjuvant chemo RT for locally advanced rectal cancer. moving on to this trial, this is the 5-year follow-up data of the Rapido trial. Rapido trial, like you know, is a Scandinavian trial, and it was published in 2021. The initial Rapido trial established that the disease-related treatment failures were lower in the total neoadjuvant group versus standard group. Here, they are looking at the 5-year follow-up data. So the aim was to analyze the scan patterns of local original failure in the patients with from Rapido trial at 5 years. They looked at 920 patients. The experimental group received short course RT followed by chemo. That is the total neoadjuvant therapy, and the standard care group received the standard long course chemo RT surgery and optional post-op chemo. And when the local original failures, they categorize into early local original failures and the local original recurrence. That is, early local original failure is no resection or R2 resection, and local original recurrence they defined as recurrence after R0 around resection. The median follow-up was 5.6 years. This is the original Rapido data. Like I said, it showed that the total neoadjuvant group had a lower disease-related treatment failure rates, but when they further analyzed the data, they realized that the lower disease-related treatment failures were because of the lower distant metastasis compared to the lower local original failures. So then they tried to look at the local original failures alone. So like you know, disease-related treatment failure can occur locally or recurrence in another organ or a distant organ. So when they analyze the data, they realize even though the neoadjuvant addition of chemo to radiation naturally reduced the distant metastasis, but it did not reduce the local original failures. But they realized when they analyzed the local original failures, they realized that local original failure was higher. Local original recurrence was 10% in the total neoadjuvant group versus 6% in the standard neoadjuvant chemotherapy group. So this was not expected. So they tried to look at why this was so, and correlating data which they found was that the breach in mesorectum was again significantly higher, 21% in the total neoadjuvant group versus 4% in the standard long course RT group. So that could be one of the reasons why there could be significant local original failures in the total neoadjuvant group. And why breach in mesorectum? Again, when they looked at the overall treatment time before surgery, just to the tune of 40 weeks in the total neoadjuvant group. Naturally, you had to add chemo after the radiation, and it was only 25 weeks in the standard group. So that could also explain creating a fibrotic mesorectum, which was more prone for injury and breach. So the experimental treatment was associated with an increase in local regional recurrence rates, whereas the reduction in disease-related treatment failure and distant metastasis remained at 5 years. So the Rapido data remains solid at 5 years, but they found that the local regional recurrence rates were higher in the total neoadjuvant group. So they conclude that the further refinement of the total neoadjuvant therapy in rectal cancer is mandated. Coming to trials in rectal cancer surgery. So this is the real trial, which was again published in Journal of Clinical Oncology in May 2024 by Zhu et al. And it compared robotic versus laparoscopic surgery for middle and lower rectal cancers. So they try to look at surgical quality and long-term outcomes for patients with middle and lower rectal cancer with robotic and laparoscopic surgery. And they had already published their interim data, which showed short-term results, that is lower circumferential resection margin CRM positivity rate and fewer post-operative complications and better recovery in the robotic arm. Over 1,000 patients were enrolled, and 1,171 patients were included in the intention to treat analysis. And the primary endpoint was a 3-year local recurrence rates, and the secondary outcomes included the 3-year disease-free survival and the overall survival rates. So this is the interim data which was published. in November 2022, which again showed, as I said, showed the CRM less than 1 mm was, that is the CRM positivity rate was 4% in the robotic arm versus 7.2% in the laparoscopic arm. And when you look at the complication rate, 16% of patients in the robotic group had at least one CD2 or higher complication at within 30 days after surgery, but versus 23.5% in the laparoscopic arm. So again, complication rates were lower in the robotic arm. This is the interim data. Now they have tried to look at the survival data. The 3-year local recurrence rate was 1.5% in the robotic group versus 4% in the laparoscopic group, so lower in the robotic group. And the 3-year disease-free survival was 87% in the robotic group versus 83.6% in the laparoscopic group. Again, lower in the robotic. Again, both were statistically significant. The 3-year overall survivals were comparable and not statistically significant. So they concluded that robotic surgery for middle and lower rectal cancers significantly reduced the local regional recurrence and improved the disease-free survival compared to conventional laparoscopic surgery. Again, another surgical trial. This is the last trial, LASER trial, and LASER trial is a Chinese trial published in Jan 2025 by Jiang et al. And in the Lancet Gastroenterology and Pathology. It was a non-inferiority trial which compared lap versus open for lower rectal cancers, that is within 5 cm of the anal verge. And over 1,000 patients were included. And the primary endpoint was a 3-year disease-free survival. And the secondary outcomes included a 3-year overall survival and a 3-year local regional recurrence rates and the 5-year overall survival. So they included patients 18 to 75 with T1 to T2 node 0, T3 to T4A node 0, or with node positive rectal adenocarcinoma within 5 cm from the dendrite line. And they looked at the basically it is a non-inferiority trial comparing lap versus open for lower rectal cancer. And when they looked at the 3-year disease-free survival, the 3-year overall survival, the 3-year local recurrence rates, and the 5-year overall survival, they were all comparable between the two groups. And their conclusion was that laparoscopic surgery performed by experienced surgeons is non-inferior to open surgery for 3-year disease-free survival among lower rectal cancer patients. So they supported the use of lap for lower rectal cancer. This is the LASER trial. Coming to radiation therapy for rectal cancer, this is the OPERA trial. It was done in France and UK. It was published in Lancet Gastroenterology and Hepatology in 2023 April. It tried to optimize the neoadjuvant chemoradiation boost in T2 to T3 rectal adenocarcinoma. And basically, neoadjuvant chemo RT, you give 45 gray of external beam radiation therapy, followed by a normally you give a 5 gray boost. Here they have tried to look at the 45 grays followed by 9 gray boost external beam radiation, or they have tried to compare it with contact X-ray brachytherapy boost. So 90 gray in 3 fractions. So the first group, both groups received the 45 grays external beam radiation in the neoadjuvant setting, and followed by external beam radiation boost of 9 grays in 5 fractions in group A, and the other received brachytherapy boost of 90 gray in 3 fractions. And for tumors less than 3 cm in group B, the contact brachytherapy was given before the neoadjuvant chemotherapy. And they tried to look at the 3-year organ preservation rates. And the secondary outcomes they looked at was the adverse events, early and late side effects. So this is how they placed it. So in the arm A, again 45 grays were given, then followed by the external beam brachytherapy boost of 9 days, and the arm B they tried to give if the tumor was less than 3 centimeter, they gave a contact brachytherapy boost followed by the external beam radiation of 45 grays. Whereas if the tumor was more than 3 centimeter, they gave the contact X-ray brachytherapy boost after the external beam radiation of 45 grays. And then they looked at if the patient had a partial response, patient was subjected to a TME, and if it was a complete response, they followed either the wait and watch or the local excision, and they tried to look at the organ preservation rates. So when they looked at the 3-year organ preservation rates in between the two groups, the contact brachytherapy group had a higher organ preservation rates of 81% versus 59% in the external beam radiotherapy group. And when they did a subgroup analysis of tumors less than 3 centimeter, the difference was much more marked, with 97% organ preservation rates versus 63% in the external beam radiation boost. So they concluded that the contact X-ray brachytherapy, especially in tumors less than 3 centimeter, were extremely effective if they could try and avoid the surgery and try to preserve the rectum, lower rectum. But the caveat was the main late side effect was grade 1 to 2 rectal bleeding because of telangiectasia. This was significantly higher, 63% in the contact brachytherapy group versus 12% in the external beam radiation boost group. But it generally tended to subside after 3 years. So they conclude that neoadjuvant chemoradiotherapy with contact brachytherapy boost significantly improved the 3-year organ preservation rates, particularly for patients with tumors smaller than 3 centimeter who were treated with contact brachytherapy first, followed by neoadjuvant chemoradiation. And this could be offered to operable patients with early T2 to T3 disease who are keen to avoid surgery and seek organ preservation. Coming to a couple of trials in colorectal cancer screening. So this is the Eclipse trial, which was published in NEJM in March 2024. This tried to look at a cell-free DNA blood-based test for colorectal cancer screening, and they found that this is a blood-based test based on the cell-free DNA, and they found it had a 83% sensitivity for colorectal cancer, 90% specificity for advanced neoplasia, and 13% sensitivity for advanced precancerous lesions. This led to the approval of the Shield liquid biopsy. That it has already received FDA approval and has been rolled into the market in October 2024. And another screening trial was the Blue Sea study, which is a next generation multi-target stool-based DNA test for colorectal cancer screening. It led on to the Cologuard test. So this Cologuard test is a stool-based DNA-based study again. The sensitivity for colorectal cancer was 93.9% with a specificity of 90%, and the sensitivity for advanced precancerous lesions were 43% with a specificity of 90%, 92%. So significantly good screening sensitivity and specificity for these, and so very effective two screening tools. One is blood based and another is stool based. So right now they are quite expensive, but I'm sure they will roll into the Indian market also. So that's all from my end. I have tried to cover most of the recent trials in colorectal cancer. Thank you. Coming this year end or so, we will have more solid data regarding the same. I will try to upload the PPT. I will give the PPT to the host. Hopefully they can give. Again, another query regarding patient selection for short course versus long course versus TNT. It depends on the institute protocol, but the standard of care is long course, especially in high risk groups, which are T3 plus or groups. The standard of care is long course chemo RT. Practically, short course RT is being uh, used in the neoadjuvant setting much more, especially in the private setting because of less patient attrition rates. But that should not be a criteria for at your level. And TN total neoadjuvant selectively, many centers have started using, but after the 5-year rapid data, many are again switching back to the long course, conventional long course RT. So, shall we wind up the session? I will try to put up the PPT